Thanks so much.
Thank you, Tom, and thank you to everybody who's made my welcome to NHS Tayside so much. Very welcome so far. So I'm going to talk about immune deficiencies. Immunologists also train in the management of systemic autoinflammatory disorders, in laboratory competencies, and in allergy. So I'm available, as are the consultant clinical scientists and clinical scientists for any advice or queries you may have. But immune deficiencies, so we define these as being, you'd think of immune deficiencies would predispose you to an increase of infections, which it obviously does, but actually the phenotype is more broad than that, and patients with immune deficiency have increased susceptibility not only to the infection, but also to autoimmune or inflammatory disease, benign and malignant proliferation, and to allergic disorders, and so it could be suspected in any of those presentations. We classify immune deficiencies based on whether it's primary or secondary. In a primary immune deficiency, it's a component within the immune system itself which is defective. In secondary, it's due to some underlying cause. As immunologists, we don't get involved too often in secondary immune deficiency other than drug-induced. And the fastest growing immune deficiency in the UK is probably secondary immune deficiency due to immune suppressives or biologic drugs such as rituximab used in connective tissue disease or hematological malignancy. Of all the known immune deficiencies in the UK in 2012, the greatest majority of those belong to the group of primary antibody disorders, and the rest are sort of a smattering of all the other components of the immune system which are defective. And when I see somebody in clinic, I have to have in my mind, is this a primary or secondary immune deficiency? And I've underlined some of the commonest secondary causes of immune deficiency that we would see. So the list hasn't been updated for a wee while because it should include some of the newer immune suppressives, including the biologics. But we'd also think of malignancies, particularly B-cell malignancy or immune deficiency caused by loss, maybe antibody loss through the renal or GI tract. So how common are they? Well, the graph on the right shows the UK registry of immune deficiencies, which started just before 2006. So between 2005 and 2012 were just over 2,000 cases. There's between 2012 and 2016 there's been roughly another just short of 2,000 cases added on, and the graph's not showing any sign of plateauing. So primary immune deficiencies are being increasingly recognised. Last week there were 4,000 alive patients on the registry, and that would correlate to about 1 in 15,000 of the UK population. I trained in Northern Ireland. Northern Ireland has a population of 1.81 million, which is about 4.5 times the size of NHS Tayside. In Northern Ireland there are 199 patients with identified primary immune deficiency. So extrapolating across, we would expect to see 45 PID patients in NHS Tayside, and we have 28 on the books. There probably are multiple reasons for this, but I want to highlight that possibly this is because they're being under-recognised. It's not just an NHS Tayside issue. For all of Scotland, there are 277 cases, whereas 585 would be expected if we extrapolated across from the north of Ireland, and that leaves more than half have not yet been detected. And that's not uncommon, and studies in diagnostic delay show a mean time of about 12 years between the onset of symptoms of your primary immune deficiency and the eventual diagnosis. So people have come out with useful acronyms to try to help you, to trigger you to think about immune deficiency. So if it's a serious, persistent or unusual or recurrent infection, that should make you suspect this isn't behaving normally and maybe there's an underlying immune deficiency. The Jeffrey Medell Foundation in the States was founded by the parents of a young man who eventually died from his primary immune deficiency. They wanted to highlight what could be early warning signs of primary immune deficiency among children and adults, to try to increase the recognition of immune deficiency and try to defray the complications before they arise. So having 2 or more of any of those following list of 10 for both children and adults should raise your suspicion that maybe there's an underlying primary immune deficiency. Sometimes the pathogen that's identified can suggest the immune deficiency. So classically for a complement deficiency, you'd expect to see recurrent meningococcal meningitis. For a phagocyte deficiency, it could be recurrent staphylococcal or aspergillus infections. And if it's a T-cell defect, then any pathogen can really occur because T-cells are really the central orchestrators of the immune system. The commonest immune deficiency that we do see would be a primary antibody disorder, and the commonest way that presents would be with recurrent sinopulmonary infections, lower respiratory tract infections, or pneumonia, usually due to Haemophilus, Moraxella, or strep pneumonia. Investigating immune deficiency then can be a bit of a challenge because you kind of have to know what underlying defect you suspect, know what pathogens and what immune deficiencies arise owing to that immune deficiency. But for a kickoff, if you were to measure the full blood picture, the serum immunoglobulins, the specific antibody response, and the HIV test, you'd probably pick up a fair amount of immune deficiency. And then the rest of the testing will really largely be directed by how strongly you clinically suspect an immune deficiency, and obviously by chatting with ourselves in immunology and helping direct your investigations further. More and more immune deficiencies are being resolved by resorting to genetic testing to look for a monogenic primary immune deficiency, of which over about 250 are recognised at the last count. In terms of what treatments we can offer for immune deficiency, we can try prophylactic antimicrobials, immunisation to try to boost their immune response, start patients on replacement immunoglobulin replacement therapy, or in some instances, if it's a particularly severe immune deficiency, consider either a stem cell transplant or a gene therapy. In the era of monogenic primary immune deficiencies, when you're able to identify a very specific molecular pathway that's defective, you can use particular drugs to block that pathway and to restore normal immune function. So I'm going to try and illustrate some of these points now in 3 cases. So the first is currently 51 years of age. In his late 20s, he began to develop respiratory tract infections, and he left the armed forces possibly because of his frequency of infections. Between the ages of 30 and 40, he had 3 admissions to hospital with pneumonia, and he had several attendances at primary care with recurrent culture-negative urethritis. He had some autoimmune disease as evidenced by vitiligo, and he had nodular osteoarthritis. And he was referred to an immunology service outside of NHS Tayside when he was 43. So there's about a 17-year gap between the onset of symptoms to the first suspicion of an immune deficiency. His initial investigation showed a marked severe panhypogammaglobulinemia. So the 3 main immunoglobulin isotypes in your blood, IgG, A and M, were all either undetectable or just detectable. He had reduction in his lymphocytes and reduction in his neutrophils and platelets, and he had a mild increase in liver function tests. He was HIV negative. So the working diagnosis at that stage was common variable immune deficiency, which I'm going to talk about shortly. Secondary causes were excluded, and he was tried with prophylactic antimicrobials. So he started with azithromycin 500 milligrams 3 times a week. But I think not unexpectedly, given the severity of his antibody deficiency, that didn't cut it. And he was rapidly transitioned to replacement immunoglobulin therapy when he was 43 years old. And after that, he really describes a life-changing improvement in the terms of infection and antibiotic usage. An ultrasound of liver showed some increased echogenicity and some mild enlargement of his liver and spleen. Vessels were patent, and it was considered this could be a fatty infiltration. He had a CT chest to look for bronchiectasis. It wasn't there, but there was a comment on some low volume mediastinal and abdominal lymphadenopathy. In 2015, he moved to NHS Tayside, and owing to the persistent elevation in his liver function tests, he was referred to colleagues in hepatology, who noted that he was drinking between 10 to 20 units of alcohol per week, and that he was overweight. Viral markers were negative, his fibroscan was abnormal, and he was advised alcohol and weight reduction. Due to the modest reductions in platelets and neutrophils, he was discussed with colleagues in haematology, but no further action was taken at that point. And really, since he transferred to NHS Tayside, there's been a pretty static liver function tests and his neutrophils, lymphocytes and platelets. So no evidence of any progression. In May 2016, he had some monitoring bloods for his CVID. Part of that might be his lymphocyte subsets, and we noted that his CD4 T cell count was now very low. And sort of borrowed data from HIV suggests that CD4 T cells in around 200, so significantly increased your risk of opportunistic infections such as pneumocystis. He went on then to have a CT chest abdomen pelvis, which showed that his spleen was enlarged. He had a very large paraesophageal node and additional nodes in his mediastinum and abdomen, as well as the additional finding of perigastric varices and new onset of bilateral bronchiectasis. So none of those nodes were particularly accessible easily, I thought, for biopsy, so I asked for a PET-CT to see if we could figure out were there any who were particularly hot that might be more possible to biopsy. So his PET-CT findings, this is the large paraesophageal node. These are all increased SUVs, and these are mediastinal nodes and abdominal nodes, and then evidence of splenomegaly on his PET-CT. Okay, so Dr. Lane Henry very kindly performed a transesophageal biopsy of the large nodes, and it showed a malignant population of lymphocytes with additional staining consistent with a high-grade blastoid mantle cell lymphoma. He had a staging bone marrow trephine, and there was no infiltration present on the trephine. So currently he's on his first or else second cycle of chemotherapy. 6 cycles are planned, and we're carefully monitoring his liver function tests. So the additional problems for this man are that he has a new onset of perigastric varices and portal hypertension. The cause is unclear. He's got newly detected bilateral bronchiectasis. And because of that sort of constellation of symptoms, I'm suspicious of an underlying monogenic explanation for his primary immune deficiency. So we've arranged for targeted exome sequencing. So his diagnosis is CVID. So this is the commonest symptomatic primary antibody disorder. Figures vary, but it's about 1 in 25,000 in Northern Ireland. There's marked heterogeneity, and the heterogeneity is probably because it's not one but many separate disorders just grouped together under this one umbrella. Most patients are diagnosed in the 2nd and 4th decade of life after multiple instances of pneumonia. It can occur in children and older adults, and by far and away bacterial infections are the most common, but any pathogen has been described. Abnormalities in the T cell compartment occur. They're usually modest but are occasionally severe, and frequent autoimmune complications develop, and there's an increased risk of malignancy. So to diagnose somebody with CVID, you exclude a secondary cause of hypogammaglobulinemia, and then they have to have a marked decrease in their serum IgG, with an additional reduction in one of the other 2 isotypes, A or M. with the onset after 2 years of age to exclude any neonatal delay in maturity of the immune system. They also have to have a poor response to test vaccination, and other causes of hypogammaglobulinemia excluded. So, I mean, lots of different disorders are probably being grouped under that one term. There are multiple manifestations of CVID. I'm sure I've seen all of these individual complications, and we will divide them out in terms of infections and inflammatory. For this man, I wonder if his sterile urethritis was due to maybe ureaplasma or mycoplasma infection, which would be, I hope I'm right to say, fastidious, difficult to grow, and in a previous patient in Belfast we resorted to PCR to get the diagnosis. In terms of liver abnormalities and CVID, there is a condition known as nodular regenerative hyperplasia, and I wonder if that's what he has. He's got bronchiectasis. He has several of these deficiencies. In terms of malignancy, the lymphoid malignancy risk in one series was described to occur in about 8.2% of patients. Most of these are B-cell non-Hodgkin's lymphomas, so that would be obviously a massive increase on the population risk of lymphoma. But solid organ malignancies are also increasingly recognised, and breast cancer and gastric cancer are frequently described. I think gastric cancer increase is, I've not personally seen it, but in the continent, for example, patients with CVID would get a screening gastroscopy each year to look for any evidence of gastric cancer, but that wouldn't be routine in the UK. So, nodular regenerative hyperplasia is just a histopathological description. It causes expansion of some hepatocytes that form islands, and between them, in between hepatocytes are being squashed with minimal fibrosis. It was originally thought to be fairly benign, but actually in the largest series, most patients belong to either group 2 or group 3. So they have evidence of portal hypertension, which obviously this man does with his perigastric varices. And on some occasions there's a superimposed autoimmune hepatitis picture, which isn't really supported by his static liver function tests. Granulomatous hepatitis, a sarcoid-like condition, is also described, and obviously a malignant infiltration from his lymphoma could be responsible. So nodular regenerative hyperplasia, so called because of the sort of nodules of tissue as they organise. There's minimal fibrosis, and there's a modest inflammatory cell infiltrate, mostly T cells. So, not surprisingly, the prognosis in CVID is mixed. If you have complications other than bronchiectasis, then your survival is much worse than if you purely have infections and bronchiectasis. So, and compared with the general population, your risk of death is increased. Since the episodes of pneumonia in CVID are decreasing, I'm sure that's due to the use of immunoglobulin replacement therapy. Worrying, though, we haven't really made any headway in the frequency of reported respiratory tract infections. And bronchiectasis does not seem to be abated by immunoglobulin replacement therapy, and that's probably supported by the continuing presence of respiratory infection, although there is a reduction in pneumonia. So the final diagnosis in case 1 was CVID complicated by a blastoid mantle cell lymphoma, bilateral bronchiectasis, and portal hypertension, I think possibly secondary to nodular regenerative hyperplasia. I think he's enough going on at the minute without pushing him through to a biopsy just now. Case 2 is a 25-year-old female. She was admitted to 9 Wells after 7 days of fever, fatigue and abdominal pain, and after her 7th day began to describe increasing abdominal pain marked in the right flank and the right iliac fossa with associated vomiting and confusion. She had a past history of pelvic inflammatory disease and previous terminations of pregnancy, and the initial diagnosis was broad. Discussion with the on-call gynecology registrar suggested pelvic inflammatory disease was the most likely, and she was commenced on these antibiotics. Her urine test was negative, her CRP was increased, and she had a leukocytosis, a neutrophilia, but normal liver tests, a normal ultrasound of abdomen and pelvis, her pregnancy test was negative, and a vaginal swab showed her profuse growth of candida. And then a CT arranged because of persisting abdominal pain showed the following abnormalities. There was stranding of the fat around the liver at the porta hepatis and near the right adrenal gland. There was additional stranding of fat in the omentum, extending to the falciform ligament of the liver. And the radiological diagnosis based on these appearances was Curtis-Fitz-Hugh syndrome. So Curtis-Fitz-Hugh syndrome is a perihepatitis. Typically it's caused by Neisseria gonorrhea, and pathophysiology unclear, but it's due to either hematogenous or lymphatic spread to liver capsule from vaginal infection. In the long term, there's a risk of chronic pain due to adhesions, and at laparoscopy, the adhesions have a violin string appearance. After she improved with antibiotics and went home, but shortly afterwards was called back by the hospital because microbiology had noticed that she'd grown Neisseria meningitis in her blood culture bottles. This was then genotyped into a rare meningococcus known as genotype E, and she was readmitted for further assessment. There was no meningism on exam. She had a rash, wasn't especially meningococcal in appearance, and she had a normal lumbar puncture and no evidence of Neisseria on PCR. So I saw this patient just last week, and then I wondered whether her Neisseria meningitis, or meningococcal bacteremia, I should say, could have been at its first port of entry been via a vaginal entry, or was this a pelvic inflammatory disease? And so I was able to dig up a case report of pelvic inflammatory disease due to Neisseria meningitis. We could have clinched it, I suppose, if the vaginal swab was positive, but Neisseria gonorrhea typically requires an endocervical rather than of a vaginal swab, and the plate would have to have additional suppressive antibiotics to allow growth of the gonorrheal colony. So it's possible that it was missed on the vaginal swab due to sampling. Because it was a rare meningococcus, the ID Reg Nick asked Liz, who's the consultant scientist, about what additional investigations were required. And it was suggested that they investigate the complement system. And the investigation of the complement system was abnormal. And functional measures of the integrity of the classical and alternative complement pathway were both reduced. And when they're both reduced, that suggests a defect in the terminal complement pathway. So then we measured the individual components of the terminal complement pathway, which were all actually normal, and some of them in fact raised. That doesn't tell me that this isn't a terminal complement pathway defect, but I suspect that she's making increased amounts of non-functional protein. So I think when we get the eventual molecular diagnosis, she'll either be a deficiency of 5, 6, or 9. We'll watch this space. And so this is the complement pathway. So she had both of these systems are reduced. So we wouldn't expect a C1q deficiency to give any problems in our measurement of the alternative pathway, and vice versa. And it's where the two overlap is where we suspect the disease has arisen. So molecular studies are underway. Further functional studies are possible, so we could reset up the experiments and add in a source of some of these terminal complement components and see if that normalizes the hemolytic pathways. And that would be a functional experiment that's performed in the National Centre for Complement in Cardiff. It's important that this patient gets immunised against additional meningococci, so she's already received vaccination against MenB, ACWY, and for good measure we've added in vaccination against Hib and pneumococcus. Once we do get a molecular diagnosis, it'll be important to screen family members because they're clearly at risk of possible fatal meningococcal disease. So the final diagnosis in this case was meningococcal bacteremia and, I speculate, Curtis-Fitz-Hugh syndrome, secondary to Neisseria meningitis, secondary to terminal complement pathway deficiency, or too many acronyms, but a primary immune deficiency presenting with pelvic inflammatory disease. So the last case is a patient I've treated in Northern Ireland. He first presented when he was 3 with an EBV primary infection. It was characterised by fever and tonsillitis, hepatosplenomegaly and cervical lymphadenopathy. His EBV IgM was positive, but because it was actually more marked than an EBV primary infection in a 3-year-old would be expected, he had a bone marrow aspirate and a CT of chest, abdomen and pelvis, which didn't show really any additional pathology. From the ages of 3 to 16, he had a mild but persistent anemia, which was not iron deficiency. When he was 16, he had 3 months of malaise and fever, and on examination was found to have massive splenomegaly, right down to his right iliac fossa, a cervical and inguinal lymphadenopathy, and a CT chest, abdomen, pelvis demonstrated widespread mediastinal and inguinal lymphadenopathy, as well as patchy changes in both lung fields. His initial results, again, were markedly abnormal. He had a pancytopenia, his liver function tests were off, he had a raise in his triglycerides, and a reduction in his fibrinogen, a massive increase in his ferritin, and undetectable immunoglobulins from each isotype. He had a modest lymphopenia, but almost no natural killer cells. And so that sort of constellation of signs, clinical signs and bloods, would point to a diagnosis of hemophagocytic lymphohistiocytosis, or HLH. So we went and looked for that, and there was no HLH on the bone marrow, but we still were very suspicious, so we got him a lymph node biopsy, and again there was no evidence of HLH or granulomas, and it was described or reported as reactive. We looked for EBV positivity in both tissue and blood, both of which were negative, and he just got better over 6 weeks. He commenced immunoglobulin replacement therapy because of his obviously undetectable pan-hypogammaglobulinemia. So HLH can be congenital or it can be acquired. It's a disease of overactivation of both macrophages and cytotoxic T cells and NK cells. Your cytotoxic T cells are unable to eradicate whichever antigen they're directed towards, and then they recruit in lots of macrophages to assist, and they differentiate, and then T cell numbers increase, and that eventually leads to macrophage consumption of normal marrow constituents, so premature red cells or platelets. So you would think of it in somebody who had the presentation as I've described, and there are actually diagnostic criteria for that. So because of his age and because of his early life significant EBV infection, we thought it was very likely that he would have a genetic defect leading to HLH. So the one at the bottom there, the XLP2, which is also known as XIAP deficiency, is where we eventually found the disorder. And what we can do is a flow-based assay where we look at, first of all, to begin with his family tree. So this is the patient. These are his 2 brothers, his sister. His father is unaffected. And we look at the expression of XIAP. We can see that it's far across to the right from the isotype control, so that's a normal expression. In the patient, it's not as far over to the right, so it's diminished, but not completely absent. And similar results are present for both brothers, while his sister has normal expression. The mother, who is the carrier, has a double peak, and so this is the defective X chromosome causing the disease in her son, and the normal X chromosome. A novel missense mutation was identified in exon 2 of the BERG4 gene. Curiously, though, his brothers aren't affected at all. So this disease was first described just over 10 years ago. There are 70 cases described worldwide. It's encoded by the BERK4 gene, which encodes a series of inhibitors of apoptosis, which are important cell regulators. And there's no correlation between the genotype and phenotype. It usually presents in childhood, and the disease can include both EBV-driven HLH, Crohn's-like colitis, splenomegaly, HLH, cytopenias, and dysgammaglobulinemia. Case reports obviously of patients presenting purely with pediatric onset colitis without any additional features, and additionally patients presenting purely with cytopenias without any additional features. So it's a very broad phenotype of expression. A bit more detail, when he was 19 he had another episode of HLH. We looked hard for infection and didn't find any, but a course of oral corticosteroids led to significant improvement and resolution of his fever. Because of his massive spleen, we tried to shrink it with sirolimus, but that had no benefit at all. Age 22, he had another episode of HLH and again got better with steroids, but by that stage we noticed that his liver enzymes were deteriorating and he was becoming increasingly breathless on a single flight of stairs for a young guy aged 22. So we arranged a further few tests. He has granulomatous disease in his liver, not previously described in XIAP deficiency. He has a marked interstitial lung disease, increased mediastinal adenopathy, and multiple pulmonary nodules. And a repeat bone marrow biopsy on this occasion did confirm the diagnosis of HLH, with some histocytes shown which are engulfing premature red cells and platelets. We went on then to arrange for an open lung biopsy. It's markedly abnormal. There shows a heavy lymphocyte infiltrate, multiple granulomas, almost stenosis of the bronchioles due to infiltration in the wall, and some evidence of organising pneumonia. The histopathological correlate with this was felt to be a condition known as granulomatous lymphocytic interstitial lung disease. It is a condition characterised by the histopathological appearance of heavy lymphocyte interstitial pneumonitis, follicular bronchitis, and or lymphoid hyperplasia. It's been described in other primary immune deficiencies, but it's not previously been described in XIAP deficiency until now. And the pathophysiology is not understood, but the treatment's directed against the infiltrating T and B lymphocytes. So most patients, I say most, there aren't that many, but most patients get rituximab and azathioprine. So his pulmonary function tests, unfortunately we don't have his transfer factor 2 months before he got his combination chemotherapy, but they were definitely on the way down, which would be consistent with his clinically described symptoms. And following combination chemotherapy, there's thankfully been a reversal in that. There's also been a reversal in his CT appearances and complete resolution of some of them. So the further treatment here is a bit of a dilemma. How long should we keep the combination chemotherapy going for? What's the risk of doing that? We have not made any headway in reversing his derangement and liver function tests or his massive splenomegaly. What to do next? Is there a malignancy risk associated with this primary immune deficiency? Are we increasing his malignancy risk with the drugs we're using? This is likely a hypomorphic mutation because he has 2 asymptomatic brothers, and his expression of XIAP is reduced but not completely absent, so there must be some additional modifier, whether genetic or environmental, who knows. So he's been referred to the Royal Free Hospital for a stem cell transplant, and he does have a fully HLA-matched sister available. That's fraught as well. The largest series of XIAP deficiencies that's been transplanted had a mortality of 50%. He's 23 years old, and he's actually on an even keel right now with his combination chemotherapy. Arguably that's as good as he's going to get until he falls again. We don't know. It's very uncharted territory. So the final diagnosis for this patient was a XIAP deficiency, a novel mutation in the BERK4 gene, and complicated by agammaglobulinemia, pancytopenia, interstitial lung disease, granulomatous hepatitis, recurrent HLH, on refractory splenomegaly. So just my last words then, I would like to say that I suspect that primary immune deficiency is probably underdiagnosed in NHS Tayside and in Scotland. I think that's probably a resource issue. There are only 5 immunologists for the whole of Scotland. That might explain it in parts. Patients with immune deficiency have a potential, adult immunologists, beg your pardon, adult patients with immune deficiency are at risk of severe life-threatening infection, malignancy, and uncontrolled inflammation. You should suspect immune deficiency for patients who have serious, persistent, unusual, or recurrent infections. And those initial screening bloods are useful, but will not identify all patients with primary immune deficiency. And it's really important that you discuss with us, either with our clinical scientists or with myself, so we can help direct your investigation. And a multidisciplinary approach is essential. So we're a small band of immunologists. There are unfortunately missing a number of people here, including our 2 lovely immunology nurses, Gail and Laurie. And I just want to say thank you to everybody so far for making me welcome in NHS Tayside, and thank you also to the clinicians who've helped me prepare this presentation.